This is the first of a small number of short recordings covering the 5 bias domains in the Risk of Bias 2 tool for looking at randomized trials. We suggest you study each video and then look at the issues raised by the trial we've given you to look at. We're only giving a very, very short introduction to each domain. There's full guidance on each of them in the literature associated with the RoB2 tool. Random allocation is a core feature of a randomized trial, clearly. We're looking for random assignment of participants into experimental and comparator intervention groups so that we can avoid systematic differences in known and, importantly, the unknown prognostic factors between the groups. Prognostic factors being the things that are predictors of the outcome. These days, most trials use a computer-generated random sequence. There are low-tech methods such as coin tossing, shuffling cards or envelopes, throwing dice, drawing lots, or using traditional paper-based random number tables. These are fine if properly implemented. There's also a method called minimization we'll see sometimes. This actually achieves even better balance than chance alone in key prognostic factors, and we tend to regard it as good as randomization. Then there are methods that we consider not to be adequate to produce randomly different groups. There's a whole bunch of methods often called quasi-random or pseudo-random methods. Alternation, treatment control, use of date of the birth to determine allocation, or day of a hospital visit, or hospital or record number. These may sound fine in principle, but in fact, we don't consider them adequate. And then there are completely non-random methods, such as the choice of the clinician or the choice of the participant, or based on some diagnostic test result, or just based on the availability of an intervention. These are clearly not random and may be introducing bias. There's a second aspect to randomization, though, which is at least as important as the use of a random sequence, and that is ensuring that the sequence is concealed. What we're looking for here is some evidence that at the point of allocating participants to interventions, the people recruiting or involved in recruitment into the study could not predict the group into which a participant would be allocated. This is to ensure that the random sequence is properly implemented, because if people know what's coming up next, it's possible to change the order in which people get recruited into the study to get in particular people receiving particular interventions, or we can prevent people getting enrolled into the study altogether in a way that depends on the allocation that they would have received, and introduce selection bias in that way. Most trials these days use a central allocation method associated with the computer-generated sequence, using a web-based system, potentially a phone or a central pharmacy. There are some low-tech methods like using a pile of envelopes on the desk of the recruiting clinician. These are okay if they're done properly, and by properly we would need them to be sequentially numbered so that we know exactly which one's next. We need them to be sealed and opaque so that people can't hold them up to the light and see what the next sequence allocation is, so that potentially they suggest the patient comes back a little bit later until the right one comes up for them. So any of these non-random methods are going to be inadequate because we can't conceal these. Similarly, a random sequence, even if it's perfectly random, if it's posted on the staff room wall so that everyone can see what's coming next, that's open to manipulation in terms of who gets what. And as I say, these envelopes or packaging without all the safeguards are potentially manipulated. And there are some special situations, such as when we're using fixed block sizes of 6 with 3 of each interventions in a random order. And as soon as we've looked at the first 5, then we know what the 6th is, if we know that there are 3 and 3 in each block. So the main assessment of randomization is to look at the methodology. But sadly, even though it's getting better, the reporting of trials for many, many years has not allowed us to know with much confidence exactly how they implemented the randomization. And that leads us to think that on some occasions we can use information about the actual people who got into the two groups to learn about whether the randomization was adequate. So we're looking at baseline balance. What we're looking for are either substantial differences between the group sizes or substantial differences in the baseline characteristics. And the latter, clearly this has got to be more than we'd expect by chance. We'll always see some baseline differences because randomization is a chance-based process. So we're not just looking for a couple of instances of statistically significant differences. We're looking for substantial, consistent differences between groups as evidence that the randomization was either not done or not implemented properly. Here's an example to see how that can manifest itself, where this is a very old trial from 1948 looking at anticoagulation, where recruitment was not done by a random process, but was done by the day of hospital admission. On odd dates, people were given anticoagulants. On even dates, they were given the conventional treatment. And we can see how the group sizes, 589 versus 442, were very, very different, suggesting that somehow people were manipulating people to be entered into the trial on odd days so that they would get anticoagulants. We have three signalling questions in the domain to address randomization. The first two issues, the sequence, was it random, and was that sequence concealed at the point of enrolling and assigning patients in the trial? And then we have a question around whether baseline differences suggest a problem with the randomization process. Note, this is not looking for some evidence of chance imbalance, which we'll almost always see. It's looking for real clues that there was something wrong with the randomization. And we turn these questions into an algorithm. The algorithms usually start with the first question, but they don't always, and this one doesn't. The most important consideration in randomization is whether the sequence of allocations was concealed. If it was not concealed, we'll match straight to high risk of bias. If it was, we'll check that there was an underlying random sequence, and we'll check that there wasn't any evidence at baseline that things went horribly wrong. Then we'll end up with low risk. If the methods seem sound in questions 1.1 and 1.2, but there's some potential problem around baseline imbalance, we may drop down to some concerns. And if the sequences are concealed but not random, we may also have some concerns. In those instances where we just don't have the information we need to know whether the sequence was concealed, all we've got to go on really is baseline information. And if that suggests that there was a problem, we'll map to high risk of bias. If it doesn't suggest there's a problem, we probably still have some concerns. So that's how our algorithm works for this domain.